I would like first to congratulate you and to thank you for presenting this astonishing data, research data, as you said, but probably an opening for clinical data in the future. And I think you've done a marvelous job, and thank you for bringing this workshop first time here in Macau and here in COGI. I'd like to tell all of you that, as mentioned, it will be in our website within 2 weeks. All this lecture will be mounted, so you'll be able to stroll and take the time and understand every step and see this. Beyond that, I understand that you've done 9 cases. Are you going to do more in the near future, or that's...
No, we just got ethical permission to do those, the 10 cases, but we decided not to do the 10th case because our preoperative investigations would be too short, and now we have to wait for the pregnancy results. And I think if we don't get any successful pregnancies in our study, we will not be allowed to do it. And it may be that uterus transplantation may go back to the research setting again in primates to optimize the procedure. So we have to wait at least until 2016 or something like that. But that's also a problem with the financing, because we were able to finance this very expensive endeavor by private foundations, and our hospital is probably not going to finance it.
You have done some embryo transfer by now.
We have done transfers or are in the process. We have done some in 4 patients, but we don't have any pregnancy results. We haven't checked for pregnancies yet.
Not yet?
No.
So
we have also said that if we get pregnancies, we will not announce any early pregnancy. We will wait, hopefully, for a live birth. And all our patients want to stay and are anonymous to the media, and they don't want to be public.
So we hold our breath.
Okay. I have a question. I'm Park from South Korea. So I really thanks for your excellent lecture. Congratulations. My question is regarding the difficulty of uterine transplantation according to type of previous pelvic reconstruction surgery. So personally, I think the pelvic space is well preserved in case of Megindo, simple vaginal dilatation, and the bead technique. But in case of Adamian technique, they use the pelvic peritoneum for vaginal reconstruction. Thus, pelvic space is not enough for uterine transplantation.
Our cases, they had skin graft vagina, self-dilated vagina, and then we had Vecchietti vagina in one case. So that is actually our experience. But if we compare to the cervical cancer patient, the surgery of the recipient was a lot easier in the MRKH patients, because that was almost novel tissue to use with. It was a lot of scarring in the cervical cancer patients. So I don't think it's going to be any problem in most of the Rocket-Hanska patients. But it may be different between different neovagina procedures. Yeah.
So I think you know the Adamian technique.
Yeah.
Adamian, they use the pelvic peritoneum.
Yeah.
So they pull down the pelvic peritoneum for vaginal reconstruction.
Yeah.
They put big pulse string suture, including the bladder, rectal wall, and post-pelvic peritoneum. They don't have enough space. So I think most of vaginal reconstruction, I took Adamian technique in 100 cases. I just worried the uterine transplantation is actually really effective or easy in my cases.
Yeah. We don't have any experience of that specific new vagina procedure. So
I just want to find out if menstruation occurred in all your patients that were transplanted?
Sorry, was menstruation in all patients? Yes. In the 7 patients who still have their uterus left, they all had menstruations that came back 6 to 8 weeks, or in some cases 4 weeks after the transplantation. And they are regular.
Congratulations. I'm Dr. Lakshmi from India. I just wanted to ask, regarding the donors, how many of them had faced gluteal pain after the extensive resection of the...
Actually, no one has complained about gluteal pain.
Okay.
And we were not really worried because we actually saved the biggest posterior branch. But of course, I mean, that's if you read the textbooks, that's...
and lymphatic obstructions?
Huh?
Lymphatic obstructions?
No lymphatic obstruction. The donors are the only actual complication we had is this fistula, and they're really doing fine. And I would say some of the donors went back to work as a dentist, for example, after 2 weeks.
Thank you.
I can comment on that also because our experience in kidney transplantations when you actually ligate or take away the internal iliac is that there is no complications from doing that. And you could actually do it on both sides without complications. So it is you could also ligate the external iliac without getting problems, and this is a knowledge that maybe is not so well known. But if you, for example, have an infection with arthritis from the infection from the arterial anastomosis, that's a life-threatening complication. I have personally taken away an organ and ligated the external, and at most they get ischemia, but not more. So I think the internal iliacs is safe to ligate.
Thank you very much for showing us such a fascinating thing. I think it's a very good experience to hear and see all these things. I just want to ask 2 questions. One, according to for the technique of the surgery, did you use any methods to avoid injury to the uterus, right? Ureteric stenting or ureter, sorry. Injury to ureter.
For the ureters, no. Actually, we didn't use any measures. I mean, we have a special forceps where you can actually grab the ureter. Was it a ureter, yes, or a uterus? Yeah, ureter without compressing
without
it.
Stenting,
no.
ureteric stent.
But as we are in radical hysterectomies, we are very, very careful with the ureters not to touch them too much and so on. But of course, it's more difficult here. Yeah. And we rather use bipolar diathermy than unipolar diathermy close to ureters. The one we had, the ureteric vaginal fistula, was the most difficult donor case. She didn't have any natural place, and the dissection of the vessels and the uterus was extremely difficult. So that's probably part of that. And now perhaps with these exit strategies and knowing the results of a fistula, in such a case we would probably stop the surgery within a couple of hours when we find out this is difficult surgery.
Okay, thank you. And the other thing, what is the first sign of rejection? How do you see in the immediate reaction? As you said, what is the first sign of rejection that will alarm you that the patient is getting rejection?
Well, what we found out, we have only had mild rejection, of course, so I don't really, I can't really answer that fully. But what we've seen is that even if it looks macroscopically fine, we have seen lymphocytes and inflammation in the cervical biopsies. So I would say the cervical biopsies is the best way.
No, clinically.
I just want to emphasize, so no one of these patients had any symptoms of rejection. It was actually just diagnosed by biopsy.
No clinical symptoms.
No clinical
like
symptoms, no ultrasound, no blood flow symptoms. So this is probably we detected it very, very early.
Okay.
I have a question about exit strategy after surgery. So if the patient don't have menstruation after surgery, so how do you think, how long should we wait for recover the menstruation?
We haven't actually thought about that, but the interesting case in both the Saudi Arabian case, you're probably aware of that they didn't get any spontaneous menstruations, was exogenous hormones, even if she was 26 years old and had normal ovaries. And actually in the Turkish case, they also started by giving exogenous hormones to get menstruations. And that is a little puzzling to me. But I think if you haven't had menstruation for 3 or 4 months, you should probably try with exogenous hormones. And if you don't get any menstruation, you should probably have to take an endometrial biopsy and see the status of the endometrium, if it's atrophic or injured.
What we saw in the non-human primates was that if they didn't resume menstruation within 4 months, they never did.
Dr. Elias Benmia from Tunisia. Thank you for the nice talk. For how long do you continue the anticoagulative therapy to avoid thrombosis first? And how and when do you remove the probe?
The probe?
Yeah, the ultrasound probe.
48 hours.
That's 48 hours. 48 till 72 hours we had the probe that measured the artery. And when it comes to anticoagulants, we had fragmin, what's that, dalteparin for 4 weeks in the recipients and 6 weeks in the donors, right? And the recipients then went on with ASA.
So they stay on low dose ASA all the time. Yeah. So the recipients actually had the low dose, low molecular heparin for 6 weeks, and the donors for 4 weeks. Yeah.
Thank you very much.
Let's say if you don't get pregnancy in 4 or 5 years, I hope you do get. But have you ever thought of shifting your research center to some other country, and maybe if you're not allowed in Sweden, you can still go on doing your surgical work, because otherwise one loses expertise also if you don't do for so many years. Have you ever thought about it?
No, I mean, we hope, of course, to get pregnancies, but we are not sure that we can get funding to do a new research study in Sweden, because it's very costly. And of course, all cases or all cases which will be done in the near future, in the next 5 years, should be done as research studies. And I think that is very important to point out. Even if you do one single case, try to follow another protocol, take all the necessary information from that case, but probably it's better to do a case series. And of course, I mean, we would also be willing to use our expertise to help other centers, but not to do it clinically, but to do it as a first-time scientific study in your own setting.
Maybe Sweden and Turkey, they can take a lead, and you can form a consortium of countries, and you can have centers at various places where you can still continue your work, and maybe if not in Swedish people, you can have pregnancies in some other parts of the world.
Yes, but I think if we don't get pregnancies out of these 9 cases that we've done in a couple of years, then we might not continue doing the human work. Then we have to see why don't we get it, and go back to the at least the primates to see it. That's the most ethical way of doing it, I think.
I think we will get pregnancies.
Of course.
Yeah, we hope. We pray.
Okay, any more questions? No? Then we just want to thank you for the opportunity to come here. We're very glad to be here, and it's very nice to see so much people interested in uterus transplantation. And of course, we will be happy to share our results in the next coming years also with you all. Thank you.